Now, I'll be talking tonight just on a few general points in COPD, and Erin and I will be sharing this talk between us. Now, I'm going to start with a slide that you're all, or should all be fairly familiar with. This is the COPDX guidelines, and these are formulated for guiding Australian treatment for COPD. I'm not going to go through it in detail. I just wanted to highlight a few areas that you might find, a bit less familiar to you. The first one here is this point in non-pharmacological interventions. So we're all aware of things like smoking cessation, pulmonary rehabilitation, etc. But when you get to this smaller box for severe COPD, we may not all be familiar with things such as surgery, palliative care, advanced care directives. I'll be focusing on the surgery side of things, and this is mostly because I used to do a bit of this, but I probably don't do very much of it now. But some of the companies which do promote these aspects have started marketing directly to patients. So you might get some more inquiries directly to you as a GP about whether or not a patient may be suitable for surgery. So this is a talk I actually gave a couple of years ago. It's on endoscopic lung volume reduction. So the actual science behind the surgery for COPD lies back in the 1950s. A group led by Otto Brantigan actually performed something called lung volume reduction surgery, and they found that by removing damaged lung within patients with severe COPD, they postulated it would increase the elastic recoil of the lung, providing room for the less damaged lung to re-expand, and this would improve your diaphragmatic contours. The landmark trial for this was published in 2003 in the New England Journal, and this was a study involving 1,218 patients with severe COPD, and they were randomised to undergo treatment with surgical lung volume reduction versus ongoing medical therapy. Now, the mortality was pretty high. It was 7.9% versus 1.3% for medical, but the 90% mortality for medical was also actually quite significant. So it does, I guess, highlight that severe COPD is a serious condition. I mean, 1.3% of patients died within 90 days. Of the surgery though, 59% of patients had serious morbidity, and some of these were cardiac arrhythmias, but some of these were a bit more serious, like pneumonia, persistent air leak as well. A post-hoc analysis performed in this group found that those with upper lobe predominant emphysema and a low exercise capacity actually had better outcomes. Like they had improved mortality, exercise capacity, and quality of life. And amongst this group, surgery, keeping in mind this was a post-hoc analysis, but surgery actually reduced short-term mortality with a risk ratio of 0.47 or relative risk, but also reduced 5-year mortality, and so this was followed up subsequently. So it was on this background that we had a landmark study showing there were some benefits for lung volume reduction, but only in a very well-defined subgroup. However, morbidity and mortality was very high in the surgical group. So there was a lot of enthusiasm initially, a lot of patients got referred for this surgery, and it was actually rebatable through Medicare in the US as well. However, this was all withdrawn after it was found that there was such a high complication rate, and it really wasn't felt that it was worthwhile to continue with offering this surgery. However, newer procedures have been developed since then, and these don't actually involve surgery. These are endoscopically performed. And there are a whole range of them, but they're all generally targeted towards reducing hyperinflation in people with severe COPD. And we're talking about things like endobronchial valves, things like glue and steam and airway crawls. Most of them are really experimental, but endobronchial valves is probably the most recognised therapy. So how does it work? Well, the valve itself is a one-way silicon valve. It's got a nickel frame, and basically the way it works is it's a one-way valve which lets air get out of the damaged lobe but not re-enter. It also allows secretions to be removed from the valve as well. So this is how it's thought to work. So say you've got a lobe, which is demonstrated there with the grey hyperinflated lobe, and that's compressing the rest of your lung, making it difficult to breathe for the patient. If you insert a one-way valve into that lobe and deflate it, that lobe theoretically improves its contour and the patient can breathe again more freely. So how's it done? It's done through the working channel of a flexible bronchoscope. It can be done under general anaesthetic or sedation only. And in some places it's done actually as a day-only procedure. This is a picture of what a valve looks like in an airway. So I won't sort of go through the science too much of it, all the results really, except to say that of the first 98 patients in whom this was performed, there was a result which was significant in about 46%. They had an increase in FEV1 of over 15%. And in 54 patients, or 55%, they had a meaningful increase in their 6-minute walk distance as well. They found that the most benefit actually came from those who had unilateral endoscopic lung volume reduction with a complete lobar exclusion. So there were some complications associated, and most of these were related to having a bronchoscopy really, and suffering a COPD exacerbation. So look, I thought I'd just really touch on that because a lot of patients have been approaching me recently who've read about this in the press. I do have a quick case report. So this is actually the first patient we did about 6 years ago now. So 66-year-old woman, severe COPD, fairly typical with an FEV1 30% of predicted, still independent and living at home with her husband. Becoming more breathless, and you can see that she's got severe airflow limitation, obstructed ratio, and significant residual volumes consistent with some gas trapping. This is a CT scan of her upper lobe showing that she basically doesn't have much lung tissue there, so mostly black bullous type change. And so the procedure was performed, endobronchial valves was successfully inserted into her left upper lobe and lingula. And this is just a picture of her result. You can see that there's one of the valves which is open and venting air, which is the way these valves function. So she didn't have any complications and was discharged after a short stay, reviewed again at 30 and 90 days, and we repeated her baseline test. So you can see her baseline FEV1 increased by 19% post-procedure, FVC increased by 37%. Her total lung capacity reduced, which is what we wanted, and also her residual volume, or her gas trapping, reduced as well. More importantly though, from a functional point of view, the 6-minute walk test increased by 26%, and she reported a reduction in her St. George's Respiratory Questionnaire score, which is, the higher it is, the worse it is. So she actually had a reduction which was an improvement. This was a baseline chest film. After the valves, you can see that the left upper lobe had collapsed, and this was sustained at 90 days. And this is what one of these valves looks like on a chest x-ray. So she reports stable improvement a year later, and she was interested in getting the same procedure done on the other side. So anyway, that was just briefly touching upon endoscopic lung volume reduction, which is, I guess, the only real surgical option for these patients nowadays. I might move on to the final point on this slide that I wanted to talk about, and that's Theophylline. So I call it an oldie but a goodie. It's actually the last step on the pharmacological pathway for severe COPD. Not a lot is understood about Theophylline, and we don't see it used very often nowadays. But just to sort of educate you as to, I guess there is a bit of resurgence in Theophylline because there has been some research done in the UK by a chap called Peter Barnes, and he's found some fairly interesting things. So Theophylline is methylxanthine, and it's in the same class of drugs as caffeine and theobromine, both of which are bronchodilators. So having a cup of coffee actually can help with your asthma, at least in the short term. And theobromine is something which is found in chocolate, so that can also have some beneficial effects on asthma. So Theophylline actually remains, despite not being used very much in Australia, it remains one of the most widely prescribed drugs around the world for the treatment of asthma and COPD. And the main reason for this is it's inexpensive. Okay? So in China, India, a lot of places it is used because it costs a lot less than the other pharma drugs we have. In Australia, however, it's considered a third-line bronchodilator after the LABAs and the LAMAs. And the COPD guidelines really say just to think about it when you've got severe COPD, which isn't really responding to anything else. The GINA guidelines, which are actually international guidelines for asthma, also mention the use of Theophylline, and this is in refractory asthma. Oops. Sorry, I went ahead and put it on slides to show. Sorry about that. No, we did. Okay. So Theophylline's actually been used for over 75 years in the treatment of airways disease, and primarily the thought was that it was used as a bronchodilator, which is why it was initially used. However, for its bronchodilator effect, you actually need quite high dosages. And at these concentrations, which were historically used, you'd get very significant side effects. A lot of people couldn't tolerate it due to nausea, vomiting, headache, diuresis, cardiac arrhythmias, and even seizures at very high doses. So it really became quite unfashionable once the LAMAs and the LAMAs were available. But there has been a bit of a resurgence in what it can do, and it's very incompletely understood how it actually works. The previous therapeutic index, which you needed to monitor carefully in the past, was 10 to 20 milligrams per litre for bronchodilation. But now we know that there is actually clinical benefit at lower concentrations, and this is evident even at doses as low as 5 to 10 milligrams. So the bronchodilator effect itself comes from non-selective phosphodiesterase inhibition. However, it's thought to also have some anti-inflammatory and immunomodulatory effects. So there's a whole list of things, and this is what you generally see when you're not quite sure how something works. But we know the top one, phosphodiesterase inhibition, is primarily what it used to be used for. But the bottom one, something called increased histone deacetylase activity, which I'll call HDAC really, is something which is thought to be its primary mode of action nowadays to increase the efficacy of corticosteroids. So expression of inflammatory genes is regulated by the balance between this histone acetylation and deacetylation. But in asthma and COPD, a lot of inflammatory genes are activated, leading to this histone acetylation to become increased. And the process can be reversed by recruiting something called HDAC. Corticosteroids, so what we use as systemic steroids, but also our inhaled corticosteroids, which Terence just talked about, they work by suppressing inflammation by recruiting this HDAC. But this mechanism is often defective in patients with COPD, as well as in patients with severe asthma, and particularly those who smoke. So you might treat these patients with a lot of steroids, and even the asthmatics who you would generally think should be responsive to steroids, they may actually appear to be steroid resistant, and we think that the mechanism may be due to this. So Theophylline is actually an enhancer of HDACs, and it reduces inflammation and reverses steroid resistance in cells. And this is cellular studies, so not in real world, but looking at cells from patients with COPD, it is shown to reverse steroid resistance. And these effects are apparent even at much lower doses than we previously used. So at 5 milligrams per ml, which is usually just a daily dose of Theophylline, you can get these effects. And at these doses, it's also much better tolerated than it was historically. So it improves symptoms and lung function and reduces the exacerbation rate. And these have both been shown in fairly small studies. And there have been some studies which have shown that withdrawal of Theophylline in patients on it also worsens lung function and leads to increased exacerbations. There isn't a whole lot of great data out there for it. It's more of a sort of a theoretical situation here. We don't have large pharma-sponsored trials because it's not a drug which they can make any money from, and unfortunately no one's sort of taken it much further. Theoretically, if we can increase steroid sensitivity and reduce exacerbations, you would also think that it may reduce progression of COPD. So I've tried to keep all this fairly brief because I think there's a lot of other speakers, and so I'll just leave this last slide up there for us to mull on, but we tried to explain some of the asterisks and various things on this slide that not everyone may be familiar with. So any questions on that? Actually,